I'm Dr. Hazm Eid. I'm a pediatric otolaryngologist. I'm practicing in Dammam, Saudi Arabia. I'm going to touch quickly this afternoon a topic which has been discussed in the panel, which was an excellent panel about the immunization and the vaccination in the CI patient. The question from the study was, who's in charge to ensure that pediatric CI patients are properly immunized? Does the vaccine specialist make any change in the vaccination compliance? The objectives: improve vaccination uptake record in the CI recipients by having an infectious disease specialist in the CI team and be part of the CI team, and also highlight any barriers to vaccination compliance. What is the level of risk of meningitis for cochlear implant? Streptococcal pneumonia meningitis CI patient has been reported to be really 16 up to 30 times higher than the general population for different type of risk factors. And with the emerging of the resistant strains making the complication even worse. The risk factor for meningitis is still the cochlear vestibular malformations, acute infection of the middle ear, implantation, and of course my topic today, which is the lack of vaccination. The main causative bacteria, as everybody knows, is the streptococcal pneumonia, which is the #1 cause, which leave a devastating result in the patients, and H. influenzae and Neisseria meningitis. Why we should vaccinate cochlear implant patient? Meningitis is a serious infection with, as I said, leaving a lot of complication behind the infection. CI patients are at higher risk for bacterial meningitis compared to the normal population. Vaccines are widely available, so there is no reason not to be up to date on their vaccination, and rising rates of antibiotic resistance with the meningitis causative factors. Important vaccination in CI, still the pneumococcal vaccine is the major vaccination, which being divided to two types. We have the pneumococcal conjugate vaccine, which usually given routinely in most of the Ministry of Health vaccination schedule up to the age of 2 years. And then we have the 23rd valent pneumococcal polysaccharide vaccine, which usually given after the age of 2 because of the immune system of children will not react to the heavy molecule of the polysaccharide only after the age of 2. This is the schedule of the high-risk patients from Saudi Arabia Ministry of Health site, showing that cochlear implant still is one of the high-risk type of patients. Important vaccination CI, H. influenzae is part of major vaccine in the vaccination schedule. Meningococcal also is the major one as well, with different type of variant and strains. The study design, we did a retrospective review of the 100 CI patients when I was a fellow in Vancouver, BC, Canada. And we found that 1/3 of the patients, they were not up to date with their meningitis vaccination type of their surgery. After that, a correction measure has been discussed to introduce the infectious disease specialist to be part of the CI team. And in 2010, we introduced the new personnel, which is the ID specialist. And a retrospective chart review of 116 CI patients has been done, showed that a big improvement of the vaccination uptake. This is the quick table showing that 9 patients out of the 79 patients whom had the first CI, they were not up to date on their vaccination. And 2 of them continue to be, because they turn to be 2 and they need to be pneumococcal polysaccharide, and nobody informed them, and still the lack of communication with the family and patient is the main factor. 10 patients, they were not at the time of assessment for CI, they were not at the up to date for their vaccination. For the second CI, which is 10 out of 37, all of them, they received afterward the polysaccharide vaccine, and they were up to date. So there was the total of 114 patients, they were up to date at the time of surgery, two only to be continued, not to be up to date. So in comparison, when we had the first review in 2007, showed that 67% of patients, they were, at the time of surgery, they were up to date. So almost 33 or one-third patients, they were not up to date. And in comparison to the second review, 2010 to 2014, which showed 114 out of 116 patients, which is 98% the vaccination update. So there's a big improvement from 67% to 98% after introducing the infectious disease specialist. The change, as I mentioned, that the 67% had the vaccination uptake. In the first review from 2002 to 2007, 98% vaccination uptake in the second review, 2010-2014. Complicating factors for not having an up-to-date schedule for the vaccination prior to the CI surgery, the misorientation and unaware parents, missed vaccination information. Many people, they come, they don't have a clear vaccination information. Young age, less than 2 years, which they need to follow the regular schedule, and then changing from the 2 years, they need to have the high-risk schedule, which is the pneumococcal polysaccharide vaccine, which is they need to be aware about it. Underestimating the vaccination importance and their devastating complications, that will, mislead and let the family and also even the medical workers not to highlight the importance of the vaccination. In conclusion, ensuring appropriate vaccination is sometimes difficult. Significant improvement after having a specialist. Here, I am not saying that you need to have the ID specialist, but you can get like a registered nurse or any personnel which can handle the designated issue. There's a way to catch up vaccination or vaccinating this population retrospectively. Significant communication gap is still there between the caregivers and the family and the patients. Parents are still currently at risk. Patients are still currently at risk. Corrective measures, no surgical date given until the complete vaccination form is on the chart, meaning not to delay the surgery at all, but that falling within 2 to 3 weeks from catching up the lack of vaccination. All patients, families who are not up to date need to get up to date their vaccination card prior to surgery, which is mandatory now, and we are implementing this in my hospital back home. Implement a pre-operative vaccination program, clinic as well. We can refer this patient to them and they can get, dealt with. Having an ID or, as I mentioned, designated personnel, medical personnel to follow up this patient is a good idea to have in the CI team. So who's responsible for the cochlear implant patient having an adequate vaccination? I think surgeons, pediatrician, audiologists, public health seems to be really everybody need to get involved in that. Thank you very much.